to everybody. I'm D Chiumello from the University of Milan. It is a great pleasure to be here with you. In the next 15 minutes, I will deal the topic how CHED CT scan can orient therapy. I have no conflict of interest, and why we have to use CT scan. This is a typical chest X-ray of patient with ARDS. What you can see is a present of bilateral disease without no pleural effusion and without any problem of the heart. According to the last definition of ARDS, patient with ARDS require the presence of bilateral infiltrate on frontal chest X-ray, and we have to exclude the presence of heart failure. But why we have to use CT scan? This was the same patient in the same moment, with the same mechanical ventilation, with the same level of PEEP, but what you see at CT scan is completely different, and you can have more interesting data regarding the clinical management of this patient. First of all, CT scan can easily show the distribution of the disease. In the upper part of the lung, in this patient, are localized the lung with normal ventilation, so without disease. On the contrary, the white area, typical consolidate area, are areas that are responsible for the shunt and for hypoxemia. In the medium, between the presence of normal lung and consolidation, there are interstitial disease, and at the bottom, the presence of bilateral pleural effusion. But why we have to use lung CT scan? Because according to the recent definition of ARDS, this was an observational study performed in more than 50 countries, and as you can see, the ARDS recognition at any time during intensive care stay was quite low, because it ranged from mild to moderate and severe from 50% to 70% of the case. And more important, this was another observational study, a real-life study, performed in a single center, enrolling all patients admitted in intensive care that underwent lung CT scan. And before CT scan, it was asked to the physician what was the reason of the acute respiratory failure. And then it was reevaluated after the CT scan. And as you can see here, only in 40% of the case, it was reached a full agreement between before and after the CT scan. But more important, in more than 50% of the case, there was a disagreement between what was thought by the physician and what was present at lung CT scan. And here, this was another study in which we compare the distribution of the disease in patients with ARDS in red and in patients with cardiogenic pulmonary edema. And we analyze the distribution of the disease according to the sternvertebral gradient. And surprising, we did not find any significant difference between the behavior of the distribution of the disease regarding the not inflated tissue and the well-inflated tissue between ARDS and cardiogenic pulmonary edema. And what's happened to patients with COVID-19? The lung CT scan quite well explain the possible difference and the possible two phenotype in COVID-19 patient. This was the same patient admitted in intensive care in the upper part, and in the lower part, the same patient after 7 days. What is clearly shown here is the low amount of the disease, the low amount of the interstitial disease compare the patient after 7 days, because in the lower part of the lung, it was characterized by a huge amount of consolidation with a lower increase in interstitial disease. But what is more important is, independent of the distribution and the amount of the disease into the lung, the severity of impairment of gas exchange was similar. So how we can combine these two situations? By looking what we found in CT scan. This was a quantitative analysis. In the blue bar are the presence of healthy lung, white in the red are the presence of sick lung. In the first case, there was a significant higher amount of healthy lung. On the contrary, here there was a significant increase in the amount of not irate lung. So this can explain the different behavior, but with the same severity of hypoxemia. So here there is hypoxemia because there is a huge amount of consolidation, there was a huge amount of shunt. On the contrary, here there was a lower amount of consolidation, you see very low amount of red bar, and the only explanation, the same severity of hypoxemia, was the presence of alteration in the ventilation perfusion ratio. This was a very recent study in which we analyzed the different behavior of patients with COVID-19 compared to patients with typical RDS not due to COVID-19, presenting the same severity of hypoxemia in the left column, and in the right column, RDS patient, not COVID-19 related, with the same characteristic of respiratory mechanics. And what we found is that COVID-19 presents a similar lung weight, so a similar amount of edema, but a significant high amount of lung gas volume compared to RDS, and a significant lower amount of not irate tissue. So this clearly explains why patients with COVID-19 should be maybe treated in the different way compared to typical RDS. And lung CT scan can help to discriminate and to understand the possible presence of recruitment, that is defined as the aeration of previously gasless lung region compared to simple inflation, that is the further aeration of already inflated lung region. What is important to understand the different behavior on lung recruitment, because these patients with different amount of lung recruitable present a different response to PEEP. This was a clear example. Same patient with RDS, same level of PEEP, low level of PEEP, and here in the right part, high level of PEEP. In the upper part of the figure is a typical patient with low amount of potential recruitable lung. You see, there is not a significant decrease in the white part of the lung. On the contrary, in the lower part, the same similar patient with similar level of PEEP, but a significant reduction in the amount of not irate area. And trying to put all the data in a large population of RDS, the amount of potential recruitable lung was quite low, because was around 10-50% of the total lung weight. And what's happened every time we increase or perform a recruitment maneuver? This was a recruiter pressure volume curve. In the red are patients with severe RDS. In blue are patients with moderate ARDS. In green are patients with mild ARDS. Independent of the severity of the disease, by increasing the higher pressure, there is a significant increase in the amount of recruitment. But the amount of recruitment was significantly different according to the severity of the disease. So increasing the severity of the disease, characterized by high amount of the lung edema, there was a high amount of recruitable lung. But look here, this was very important. By increasing the higher pressure from 40 to 45, it was not associated to significantly change, a significant reduction in the decrease in not erect tissue, so no difference in the recruited lung tissue. And a different behavior can be present in pulmonary and extrapulmonary ARDS. Pulmonary ARDS are usually defined patients with pneumonia. Extrapulmonary ARDS are patients with sepsis or trauma. And by analyzing the lung recruitability at CT scan, patients with pulmonary ARDS were associated by a significant high amount of lung recruitability and a significant high amount of not inflated lung tissue. And again, here is the frequency distribution of the lung recruitability in the pulmonary and extrapulmonary ARDS. Black bar are pulmonary ARDS, and as you can see, the pulmonary ARDS were characterized by a high amount of potential lung recruitability. But it is possible to use, for example, lung intersound to predict lung recruitability. We perform a crossover study in which ARDS patient underwent two levels of PEEP, low and high level of PEEP. And in the same level of PEEP, we perform a lung CT scan and lung ultrasound. Lung ultrasound was applied with a lung score in which the change in the morphology were taken to perform a score. And here are the results. So we found a good relationship between the lung density and the lung ultrasound score at the two levels of PEEP. And similarly, we found a good relationship with the amount of not erected tissue and the lung ultrasound score. So higher is the lung ultrasound score, higher is the amount of not erected tissue, and high is the amount of the tissue density. But looking the lung ultrasound score that could range from 0 to 1 to 3. 0 is a normal lung, 1 is a lung with moderate presence of interstitial disease, 2 present with severe interstitial disease. A score of 3 means consolidation. And here are the lung density by CT scan. We found a good change between 0 and 10 and 3 to characterize the severity of the disease. But the problem comes here. Here are the same lung ultrasound score, 0 and 1, 2 and 3. But for the same lung ultrasound score, the lung was constituted by different and by overlap of lung disease. For example, for a lung ultrasound score of 0 and 1, it was characterized by a high amount of normal, well-aerated, pulmonary, and not aerated tissue. And on the contrary, for a lung ultrasound score of 3, it was characterized by a large amount of not aerated tissue, but with this also present of pulmonary aerated tissue. And by try to a relationship between the change of not irritated tissue from low to high level of PEEP, so the reduction of consolidation, and the change in the lung ultrasound score, we were not able to find any relationship. The last point is maybe we can use a lower dose, a lower amount of radiation when we perform a lung CT scan in our RDS patient. This is a typical CT scan performed with a standard dose. This was the same patient in which we reduced the dose of radiation. And as you can see, there was any different. Then we perform a quantitative analysis, and this is a blind Altman to evaluate the possible difference between the standard dose and the reduced dose. We didn't find any difference between the two techniques. So how we can conclude? The lung morphology can be assessed by CT scan or lung ultrasound. However, if we were to estimate the amount of the disease, the distribution, we have to apply lung CT scan. The recruitment as the change in not related tissue is possible with lung CT scan, and the change in the lung ultrasound score are not related to the tissue lung recruitment. Thank you very much for your attention.